some of you meeting up in person, but we also extend the welcome to those that are listening in and watching on Zoom. A Californian at heart, Dr. Wynne Armand received her Bachelor of Arts from UC Berkeley, medical degree from UC San Francisco, and internal medicine residency at UCSF in a primary care program. She relocated to Massachusetts General Hospital to practice primary care at hospital, to practice primary care at the MGH Chelsea Healthcare Center, serving a large immigrant population. She's an assistant professor at Harvard Medical School and she co-directs Primary Care Office Insight, a resource hub available to clinical teams and patients, and focused on education and the optimization of primary care delivery across Mass General Brigham. She is an associate director at the Mass General Center for Environment and Health, whose mission is to integrate sustainability into hospital operations, education, and research, and to advocate for policies that support a healthy environment for everyone. Dr. Armand will be speaking to us on health sector emissions, opportunities for mitigation. Thank you. Welcome.
So thanks for coming, and I appreciate that kind introduction and the invitation. So again, thank you very much. So you've heard the title, Health Sector Emissions and Opportunities for Mitigation. I was asked to begin by sharing something personal, and I thought I would share with you the story of how I came to this work and how I ended up being here with you today, giving this particular talk. I think that many of us in mid-career start to reanalyze where we want to go and what the focus of our career should be. Much like the beginning of the career, I think that happens again mid-career. And for myself, I started a handful of years ago doing these exercises with journaling, writing, and then really trying to see if I wanted to redesign my sweet spot. And so for those of you that don't know about the sweet spot, it's a way of thinking about what career is most suited for you. And it's finding that intersection of what you know how to do, so what you are feeling experienced in, what you feel good about, knowing how your capabilities are. And the intersection then secondly with what you feel passionate about, something that is very important to you. And then the third piece is where there's a job, where there's a mission. So finding that intersection. And I remember being in my backyard. This is actually not my backyard, but I wouldn't mind if it were. And I was reading The Overstory, which was written by Richard Powers. And I felt extremely amazed by the ecosystem that he described in the book, but also feeling very concerned about the vulnerability of our ecosystem and what was happening and what was going to happen. And I realized at that time that I really wanted to dedicate and integrate as much as possible into my career at Mass General Brigham and my work outside of Mass General Brigham to addressing climate change. And so I thank you for allowing me to share that story. And if at some point, either after the talk or even by email, you have a story similar or different that you'd love to share, I would be happy to hear it too. So we will talk about health sector greenhouse gas emissions, and I will try to identify some clinically relevant examples of opportunities for us on how we can decrease our emissions in healthcare, using examples in asthma care, environmentally preferred purchasing, and topics within low-value care, and finish this conversation with bringing up a conversation about how we can think about culture change among the stakeholders that all have a part to play in this process. So I'm going to try to whiz through a little bit about the climate science background. This is a graph that shows you, based on ice core data, the CO2 concentration over the last 800,000 years, CO2, carbon dioxide being one of the primary greenhouse gases. The second graph shows you from 1750 on. The blue is the atmospheric carbon dioxide concentration. The gray line represents our human production of carbon dioxide, and you can see how closely they mirror each other. This third graph shows you at the baseline the average temperature for the 20th century. All the blue bars represent years that have average temperatures that are cooler than that baseline, and all the red bars show you years that have average temperatures hotter than that baseline. And you can see how closely it tracks along with the carbon dioxide concentration. We know that fossil fuel combustion is creating greenhouse gases that traps heat and is leading to climate change. And that leads to a number of human morbidity and mortality through a number of pathways, which we won't talk about today, but if you want more information, there's a lot of resources, including the New England Journal of Medicine has a nice interactive climate section. I think it's important to also consider that fossil fuel combustion is creating a lot of air pollution that creates particulate matter and gases that also are affecting human morbidity and mortality. It's estimated that just from fossil fuel combustion, the particulate matter, ultrafine particles alone are contributing to 9 million deaths globally prematurely per year. And then there's an interaction directly between climate change and air pollution. So we are witnessing across the world indirect and direct effects of climate change and pollution, and even in our own communities. And this is why 2021, over 200 medical journals jointly published a call to action to our leaders to address this greatest public health threat, climate change. Meanwhile, the IPCC in 2022 published their sixth report identifying the impacts of climate change, especially on vulnerable populations, and calling on the health sector to mitigate their emissions. And that same year, the White House came out with a health sector pledge. And I congratulate UC San Diego because you guys have signed on to this voluntary pledge to reduce your emissions by 50% by 2030 and reach net zero by 2050. But it's not just it's also national academic organizations and a number of other federal and the Joint Commission have come out with a call to action with collaborative groups and primers and certifications to try to address healthcare sustainability. But it's not just these organizations, it's also the healthcare workers that care and want action. According to this survey of 1,000 US clinicians, the vast majority wanted their hospital to do something, felt like it was consistent with the organization's mission. They felt like they themselves should do something, and also felt like it would actually impact their consideration of taking a job with an employer, depending on what their policies were related to climate change and sustainability. We found the same at Mass General last year. We offered a quality incentive program to all of our clinically active physicians. 95% completed these educational modules on climate change and healthcare sustainability. And 3/4 felt like these topics were relevant to them as individuals, and 2/3 felt like it was relevant to them in their clinical practice. So what can we do? What do we do? First, I think it behooves us to understand where our emissions are coming from. If you take the whole entire world's healthcare emissions, the US is responsible for 1/4. So 25% of the whole entire world's healthcare emissions come from the US. If you look at Eckelman-Sherman's paper in 2020, which is often referenced, and they looked at the footprint of healthcare emissions and estimated that it is 8.5% of our country's total emissions. We emit more in the absolute and per capita than any other country, as you can see by this x-axis in terms of our greenhouse gas production per person, but we do not see commensurate healthy life expectancy, as you can see by the y-axis. So where are our emissions coming from? Well, the greenhouse gas protocol defines them into 3 scopes, scope 1 and 2 and 3. According to the Eckelman and Sherman paper, the vast majority is scope 3. So let's go through each one. Scope 1 is what we directly are emitting. That's the on-site refrigerant release, our fuel that we use in cooking, our fleet vehicles. It also includes our anesthetic gases, but that was not included in this particular study. Scope 2 is our purchased energy. So it's all the energy that we need to operate our equipment, to heat and cool our buildings that we are purchasing. And scope 3 is everything else, essentially, our indirect emissions. That's the supply chain, our pharmaceuticals, our equipment, our food, our staff travel, and also investments and meter dose inhalers, which are not included in this particular study. Now, patient travel technically is not in these scopes 1 through 3, but most people clump it under scope 3. So at Mass General Brigham in 2022, we did a complete footprint of our institutions, our 2 academic hospitals, Mass General and the Brigham, as well as all of our community hospitals and clinics. It included our clinical operations, our research, and our administrative functions. And you will see that our scope 1, 2, and 3 align almost identically with the Sherman-Eckelman paper. So if we look at our own Mass General Brigham's scope 3, you can see that about half of it is the purchased goods and services. That's everything that we are buying to deliver the care, the manufacture and distribution of these materials to our hospitals. The next segment is capital goods. So that it would be the building, the new building, the renovation, the big expensive machines like MRI equipment. The next big chunk is upstream fuel and energy. So that's the emissions that's associated with the extraction and delivery of the fuel and energy that we are purchasing. And then you'll see commuting is actually not an insignificant piece. I'll call that out because that is an opportunity for mitigation, but we are not going to talk more about that today. And then I'm going to call it also the waste at 1%. I think as healthcare staff, we see all the waste that is being thrown in the trash. And that is, I think, oftentimes the most compelling. And I find that in our hospitals, oftentimes staff are very focused on the recycling because they see all of that waste. But 1% is referring to what it takes to incinerate the regulated medical waste, bring it to landfill. But there is a whole upstream footprint of all that stuff that's going to trash. And that's really represented in the purchased goods and services. So if we look at that biggest chunk of our purchased goods and services and our footprint, 10% of that was our inpatient pharmaceuticals. Now, we were not able to capture the outpatient ambulatory medications at retail pharmacies. But if you look at the National Health Service at the UK, about 60% of their pharmaceuticals came from outpatient ambulatory retail pharmacies. So we can expect that our footprint is actually probably double that. And then the rest of that purchased goods and services, again, is all the stuff that you see in the trash, for example. And so this is where our case examples are going to come from that I'll be talking to you about in the next hour. But I think it is interesting to also break it down a different way. If we look at the National Health Services again, you'll see that they also divided their footprint according to what is acute care versus ambulatory care. So acute care meaning intensive care unit, hospitalizations, ED, and you can see how resource intensive and how high it is in terms of emissions. And I'll call your attention to primary care. Again, 60% of theirs is medications, 13% is their metered dose inhalers. And I think this is instructive for us because this is all what you guys are already doing is addressing our emissions, meaning the important care that you deliver in terms of chronic disease management, preventative care, advanced care planning. All of that is actually important work in terms of addressing our emissions if you look at it this way. So the NHS, the National Health Service from the UK, has very robust data because for decades they've been tracking their emissions. No, they require all of their entities to track and report. This is their roadmap to net zero by 2050. I don't expect you to read all the color-coded fine print, but if you look at the red dot at the top, that's where they would expect to be if they did nothing at the end of this graph at 2050. If you follow the blue dotted line on the bottom, that is where they would expect to be by 2050, net zero, if they did everything. So let's clump it. The purple wedges at the top, we can categorize are all the emissions that they reduce by working on their decarbonization of their electrical grid and transportation. The bottom purple chunk is I would categorize as decarbonization of their supply chain, a circular economy. The middle pieces I would categorize as what we can do in terms of the way we deliver our care and local health system sustainable solutions, and those are where our examples are going to come from. I'll call your attention to the sky blue wedges in the middle. That is the piece of mitigation that you can expect by addressing anesthetic gases and meter dose inhalers, just to call your attention that it's not an insignificant piece of their solution. So though today we will focus mostly on clinical examples that I think feel more relevant as physicians and trainees and clinical staff and our patients, I do in the next remaining time will call out using the yellow icon other stakeholders where we can as clinicians can engage in this work, including our non-clinical departments like environmental services, materials management, e-care team, and even more farther removed are regulatory bodies like the Human Health Services, FDA, our insurers and pharmacy benefit managers, and our regional energy infrastructure. These all may seem much more remote than what we do in clinical practice, but I think there are still opportunities here for engagement. And I'm going to take a few seconds to just sidetrack a little bit and share an example from Boston Medical Center. Anna Goldman is a primary care physician. She is also their medical sustainability director. In the last year, she co-launched an initiative called Prescription for Clean Energy. So she engaged Boston Medical Center to invite them to use their solar panels and participate in community solar. Both Massachusetts and California offer community solar. Those energy credits that they received from energy solar then were diverted to their energy burdened patients at Boston Medical Center. So the patients that could not afford their electrical bills, they got up to $50, it was $600 a year in energy credit. Meanwhile, because of the IRA, the Inflation Reduction Act, Boston Medical Center got 20% of tax credit. So here we have a primary care physician engaging her hospital, using government tax laws to then work with Eversource, who provides the local energy, and then deliver benefits to vulnerable patients that they serve. So I think there is room for engagement across all of these stakeholders and as we try to mitigate our healthcare emissions. So moving on to the first example, asthma care. So the NHS estimates that their meter dose inhalers is 4% of their entire health system's footprint. If you remove what is not really directly under our control as a hospital, and you look at the chunk that is within our control, that 4% becomes a much bigger piece of that pie. Seen another way, if you look at the NHS, all the electricity that they use to operate their all the healthcare is on par with the emissions from their metered dose inhalers. And the natural gas is about double that. So why is that? If we look at our current metered dose inhalers, the propellants that are used are HFA gases that are extremely potent greenhouse gases. They have global warming potentials 1,500 to 3,600 fold more potent than carbon dioxide, meaning they are going to trap heat 1,500 to 3,600 times more than carbon dioxide over 100 years. If you look at the more potent greenhouse gas, the HFA 227, those are basically all of our ICS formoterol inhalers as well as mometasone. If you look at the amount of inhalers in the US that we prescribe in 1 year, that's equivalent to driving 500,000 cars for an entire year. So if you look at the actual footprint from cradle to grave and you compare our options for portable inhaled devices, the two on the left are dry powdered inhalers. The two on the right are the meter dose inhalers equivalents. And this table does not include soft mist inhalers, but I hope you'll trust me and that it is fairly comparable to the dry powdered inhalers. You can see that the meter dose inhalers are 20 to 30-fold greater in their emissions in their lifespan. And the vast majority for meter dose inhalers is during the use phase and disposal phase when the gas is leaking into the air. Whereas the dry powdered inhalers, the largest chunk is the manufacturing. But even along that line, you'll see that the dry powdered inhalers emit lower even if you look at just the manufacturing phase. If you then include the spacers, the plastic spacers that are recommended for use with meter dose inhalers, that difference becomes even greater. So here is an opportunity for us as clinicians that when we are prescribing meter dose inhalers when we are prescribing inhalers and there is an option for a dry powdered inhaler and there's clinical equipoise, I think it behooves us to really think about preferentially prescribing the dry powdered inhalers. And when you look at studies that actually look at this in real world regimen, that environmental impact difference still continues to be there. If you look at, this is the higher income countries assigned by quartile in terms of what devices they prescribe. On the far left, the S is Sweden. You'll see that they prescribe just 13% meter dose inhalers. On the far right is the UK. They are prescribing 70% meter dose inhalers. If the US were on there, we would be even further to the right at 88%. If you look at the mortality according to country, you can see that the countries that prescribe mostly dry powdered inhalers fare pretty well. In fact, one might think that they actually do better in terms of asthma mortality outcome. This is by no means meant to imply a causative effect, but just that there does not seem to be a mortality difference depending on whether you're prescribing heavily dry powdered versus meter dose inhalers. Meanwhile, what do patients prefer? This German study, which was not industry sponsored, taught patients how to use the different devices. The vast majority preferred multi-dose DPIs after they were taught proper use. Now, the second opportunity I will call out for asthma care is looking at the canister size. If you look at albuterol, there are 3 different canister sizes. They all have the same actuations per inhaler. They all have the same amount of albuterol delivered per actuation, yet they differ 3-fold in size, and that is all essentially the propellant. So that is why they have actually a 3-fold difference in their emissions. I will note that actually albuterol does have a dry powder form, but I think most of us don't prescribe it or don't know about it because it's not well covered. And so this is where insurances come in, and oftentimes they dictate what we can prescribe. Here is an opportunity for us to advocate as clinicians. For example, Medicaid gets a large kickback rebate for brand name prescriptions. And so the top 2 albuterols are no longer available as a brand name. They're only available as generic. So when we prescribe for our Medicaid patients, are forced to prescribe Ventolin, which has a 3-fold higher footprint. So I think this is an opportunity for us in terms of lobbying with insurance benefit managers, but also with Medicaid. So as clinicians, we can think about, again, when we're if we're using and prescribing albuterol, choosing the lower canister size. And here's another opportunity to engage our e-care, our IT, within electronic medical records. This is an avenue where we can teach our clinicians. We can even integrate defaults into this. We can make the default the 6.7 size. We can make the default 0 refills, so that we are alerted to when patients are requesting a lot of refills, because when they do, that's going to signify that they have uncontrolled asthma. So that brings us to the third piece of asthma care is how can we improve disease in our patients with asthma? Well, we know, as I alluded to, that when people are using a lot of canisters, that means they're not controlled. And we know that even at 3 canisters a year of albuterol, there is a higher signal for mortality. Meanwhile, a post hoc analysis looks at the carbon cost. So this particular study included hospitalizations, emergency room visits, ambulatory visits, as well as medications. And you can see there's a threefold difference in the footprint of emissions. And the vast majority of that is coming from the albuterol, the short-acting beta agonist, as represented by the blue part of that bar. So here, all of our goals align. Obviously, controlling asthma benefits our patients, that it also addresses equity because we know that asthma, there's a higher disease burden in our patients who are persons of color or lower income. We know that asthma has very high healthcare costs, and now we know that it is also associated with a lot of greenhouse gas emissions. So a lot of co-benefits here. So how do we improve asthma control? Well, we have guidelines. We have GINA, which is updated every year. We have the US NAEPP guidelines from 2020. Note that they both include SMART, which is single maintenance and single maintenance and rescue therapy, which is off-label. There's also a growing trend, a paradigm shift in how we treat asthma, incorporating anti-inflammatory reliever, meaning that whenever patients are using a rescue medication, they really should be using an inhaled corticosteroid for its anti-inflammatory effects, because we know that they have better outcomes. So if we are trying to prescribe in an environmentally conscious way, what are our options? They're not great in the US. So we talked about ICS formoterol. We mentioned that already, that it's a more potent HFA propellant. And so one canister of the Symbicort, which is budesonide formoterol, is one canister is like driving over 115 miles in a car. Whereas other countries like the UK, much of EU, China, other Asian countries, and Canada all have a dry powdered inhaler form of Symbicort, but not the US. So if we had a dry powder form, we would be at the very bottom in terms of that lowest bar in terms of emissions. I'm going to go off on a little sidebar here again. If this is of interest to you, I will humbly encourage you to read the blog that I published in Healthcare Without Harm, calling for AstraZeneca to bring Symbicort DPI to the US. And within that blog, it explains, it goes through some of the considerations. It also has a link to an open letter, which we penned through Greater Boston Physicians for Social Responsibility. And if you're interested and you want to sign that letter, I encourage you to do so. But if you can, do so by the end of the month. Since this open letter came out, we've had a couple of exchanges with executives at AstraZeneca, and we actually have a meeting with them in the beginning of November. So it'd be great to get more sign-ons before that. So moving on, what are our other options? Well, we could prescribe inhalers as an ICS and albuterol as two different inhalers. Let's say best case scenario, we on the formulary, we can prescribe a dry powdered inhaler form of the ICS, and we know we're going to prescribe the smallest canister of albuterol. That would be our footprint there of the two bottom bars. But we know that 2 canisters is not easy for patients. And even if we look at the PREPARE trial, patients reported adherence 80%, most or all of the time, but that is probably an overestimation of their adherence, because other trials that look with digital counters, we know that that is actually probably a gross overestimation. We do have a third option, which now came out this year, called AirSupra, which is budesonide albuterol. But again, that's not well covered, and it's $500 on GoodRx. And based on that canister size and propellant, it would be like prescribing, you can see the footprint there, the third bar. It's like as if you were prescribing a large canister of albuterol. And then the last thing to consider is that we actually don't know which is better for our patients. There have been no head-to-head trials between ICS formoterol and ICS albuterol. But if we look at just the greenhouse gas emissions, if a patient is using Symbicort, budesonide formoterol, 4 puffs in a day, that would be equivalent to 10 puffs of budesonide albuterol because of the different HFAs that they use. Now, this is not to encourage and say that you should do one versus the other. I'm just highlighting how complex this is. And if we want to be prescribing in an environmentally friendly way, it gets complicated. And I think we need more data on this. There are other ways, of course, to improve asthma control, which we did not talk about today. First of all, addressing climate change and all the environmental triggers, and speaking to our patients about how they can avoid environmental triggers, how they can protect themselves when there is bad air quality, wildfire smoke, indoor air quality with gas stoves or cigarette smoke, how to properly use their inhalers. And then I'll just mention that ideally, patients should be disposing their metered dose inhalers in these MediSafe boxes. It is still the greenest way. These are then incinerated. It is still a lower footprint than having these canisters leak in landfill. Okay, so moving on. Our next opportunity for mitigation, let's talk about environmentally preferred purchasing. So we have so much technology available to us in the US. We have so many options when it comes to what type of medicine, what type of test we're going to order, what kind of equipment we're going to use. And oftentimes we may not have as clinicians much say. These are already they may be already determined by the materials management team or other executive leaders within our health system. But I think that we as clinicians can be speaking up that we want our health system to be doing sustainable procurement. And if your health system is not already doing that, there are toolkits that can guide the process of how to make sure that you are procuring your equipment and devices in a sustainable way. Meanwhile, as clinicians, I think there is a role for us to give feedback about what equipment, what tests, and what medications we want to be able to use in our health system. And more, we have more data to drive our knowledge in terms of like what is more environmentally friendly through life cycle assessments. So if you look over the last few years, it is just accelerating at a rapid pace. Every specialty now you can find life cycle assessment studies. This is using a methodology to quantify the environmental impact of products, processes, or tests from cradle to grave, from raw material extraction, production, manufacturing, use, disposal, recycling, summing up all the emissions to land, air, and water. So let's take an example. I chose Donahue's life cycle assessment of specula. So if you're going to critically look at a life cycle assessment, I think it's important to identify first what the functional unit is. You want to make sure the study is comparing apples to apples and not apples to oranges. In this particular study, she's looking at 20 GYN exams. Then the other thing to think about is the system boundaries. This is what everything that is being counted in the study within that system. So sometimes there are studies that show different things, and it's kind of confusing why one product looks better in one study, but they seem the same in another study. And sometimes it's because they're looking at different things within the system. And in this particular case, Donahue's including the raw materials, the production, transportations, the waste, but also the disinfection and sterilization when she compares plastic single-use to reusable stainless steel specula. And so what her study identified is that you can see at 4 uses, essentially, those lines cross. So the blue is the plastic, the footprint from plastic specula, and then as you can see, as you go along with uses, that line is increasingly higher compared to the gray and the orange lines, which represent the 2 reusable specula. And as you see, with more and more uses, that differential in terms of emissions on the y-axis is getting wider and wider. So by 4 uses in terms of environmental footprint, we can see from this study that it pays off to use reusable steel specula. Now, every hospital is going to be different. If you use a plastic specula with LED lights, your blue line is going to be much steeper because that's going to have more emissions. If you are in an area that has a wonderful renewable electrical grid, your gray line and orange line will be flatter because you will be emitting less when you use your equipment to sterilize. But I think these LCAs give us a sense as we make these decisions, and I know we will be including a lot of factors when we decide what we prescribe, what tests we order, what equipment we use, from safety, efficacy, patient preference, ease of use, regulations, infection control, costs. But I hope you will agree that we as clinicians really also need to and should be including environmental impact. And now we have more data that allows us to include this information as we make our clinical decisions. So let's move on to low-value care. Low-value care is care that is expensive compared to the benefit. And so that can be care that is either inefficient, ineffective, unwanted, or delivered in the wrong place. And so let's talk about pharmaceuticals and lab tests. So pharmaceuticals, we prescribe a lot, almost 7 billion prescriptions in 1 year. In primary care, most visits are associated with a prescription. We pay a lot as a health system and as patients, and many are necessary. If you look at antibiotics, it's estimated that about 30% of antibiotic prescriptions are unnecessary. And now you know that pharmaceuticals is about 20% of our scope 3 greenhouse gas emissions. And that's just upstream with the production of the pharmaceuticals. There's all the downstream of delivery of the pharmaceuticals, all the bags, the plastic bottles. And on top of that, we spend a lot on just over-the-counter medications, vitamins, supplements, and we haven't even addressed all the other environmental toxicities that come with pharmaceuticals. So I think I'm going to say that it's sort of like voting. It might feel like every one of us, each one of us, it's just a small piece, but collectively, if we all take action, it's actually a big piece. And as we think about how we prescribe thoughtfully, there are co-benefits. As we know in our older patients, using a lot of medications, have drug interactions, side effects. There are benefits to patients if we are thoughtful about how we prescribe. But now we also know that this is actually one way for our health sector to reduce our emissions. So maybe we should reconsider whether over-the-counter supplements are actually really harmless when our patients ask us. Maybe we should be talking to our patients about why it's not good to stockpile and avoiding unnecessary refills, and think about when we prescribe, maybe it makes sense to prescribe smaller quantities when we're initiating, titrating, or prescribing as needed medications. So the last example is going to be about unnecessary lab tests. And I like this example because this is actually driven by a trainee. This was Peter Trin, who in April, as a Brigham and Women's resident, presented this abstract to the Society of Hospital Medicine. He educated over 6 months the general medicine service about the how routine lab tests and stable inpatients were unnecessary and low-value care, and spoke to them about what that carbon footprint represented. And at the end of 6 months, the teams that actually were educated about this ordered significantly fewer labs, patients underwent fewer venipunctures, and though those emissions, those savings is perhaps not a huge amount, but if you think about collectively across all inpatient services across the health system, how these really do add up. And it's actually the beginning of culture change, because our trainees are our future educators, our future leaders. And I think it's important to engage our trainees in these conversations. And so let's talk about culture change. One of the stakeholders that we had on the initial slide were our patients. I'm just curious, who here talks to their patients about climate change? Anybody talk to their patients about the impact on the environment from their treatment? So I think you probably all have heard about the Gallup poll, how nurses and doctors are thought to be the most honest and ethical professionals. It turns out when patients are asked who is their most trusted source of information about health effects, specifically from global warming, their primary care doctor was number one. They were more trusted than family and friends, the CDC, climate scientists. But yet, I think as physicians, many of us don't talk to our patients about this, and oftentimes we actually don't know where to start. So if you are interested in learning more about this, learning about keywords and messaging with your patients, Eco America has a nice toolkit that can lead you through this, as well as other. If you check out their website, they do have other learning modules. And later, if you have questions, I'll point you to Bruce there in the audience, who can also speak to this. And it turns out our patients actually probably do want to know. And I'm going to turn back to inhalers again. When the UK did a survey of 12,000 patients with asthma or their caregivers, and they were asked if they were offered a choice to use a dry powder inhaler for environmental reasons, would they want to switch? 60% said yes, 20% said they didn't know, 20% said no, which is, I think a pretty small proportion who straight out said no. So 80% weren't sure or would. And then when they were asked whether people should be encouraged to switch to a more environmentally friendly inhaler, 85% said yes. So it might be actually that our patients do want to know about this. So when we think about talking to our patients as stakeholders, I think there are maybe 3 different levels of ease and how we can think about this, with the first level being discussing with them the health impact of climate change and pollution. This will allow us to help them reduce their exposure, but it'll also help us ensure that they have adaptive resources to stay safe. Then maybe the next level of conversation is talking about co-benefits. These are benefits that directly help our patients, but also help our planet. So going meatless a few more days of the week or month, getting exercise and walking instead of driving would be examples of co-benefits that we can discuss with our patients. And then maybe the third level, which maybe is a little bit more challenging, but with, I think, culture change, maybe will become easier and easier. Factoring in the environmental impact in our shared decision-making, whether it be about which tests to order, because they clearly have different footprints, and we have more information on this as more LCAs are being published. Factoring in environmental impact of the medications and the fish oil that they're asking you about. So we've spent quite a bit of time talking about a big topic, and I hope that the examples that we shared felt clinically relevant somewhat, but I also hope that I convinced you that as clinicians, we do have a voice and a role across all of these stakeholders. I think that for many of us who are interested in addressing this issue of climate change and sustainability, it can feel daunting and overwhelming. It's hard to know where to start. And I think that is a reason why, if you're interested in this, to try to engage with these groups that already exist. It's great for learning, it's great for networking, but it's great for our own resiliency as we try to do this work. I put up some examples here that are either government organizations or physician-led, grassroots. But I know that in San Diego, there is a pretty big community working on this, and you have your own local groups here. And I know that you have a sustainability director and are doing already enormous work. So I suspect that you will have other connections that you can make on a local level. So in conclusion, I'll summarize by saying that the health sector has a substantial environmental footprint, and that clinical care is the driver for admissions, which underscores the importance of how healthcare is delivered and of minimizing low-value care. And that a substantial source of the emissions are coming from our pharmaceuticals, and that the metered dose inhaler propellants deserve particular attention in the roadmap to our goal for net zero emissions. And that environmental impact should be considered in decision-making and is increasingly achievable. And that there are many stakeholders involved in the mitigation of health sector emissions, and that we as clinicians have important voices to engage and influence the other stakeholders. So thank you so much for your attention. And okay.
Yes.
Oh.
Thank you so much for a really interesting topic. I must admit that I myself have not really thought about this when I meet my patients. So I hope we can have a healthy discussion here, that this has provoked both the auditorium here and the people on the Zoom call. So any questions now? Let's see if the auditorium has anything. Yes.
Thank you, Dr. Armand, for that thoughtful presentation. I am a primary care doctor, and I have to admit that I do not talk to my patients about this. I know it's very important, but I struggle with um, time. I know that that's always the biggest barrier. Do you have any suggestions for us as primary care doctors who do want to address this issue? I mean, there are so many issues right now with vaccine hesitancy, colorectal cancer screening. There's so many priorities that we have for our patients, and I completely agree that this is a critical one, but I struggle with finding the time to add it.
I completely agree and share that struggle. And I think oftentimes it can be just a phrase or a word, where if I'm talking to my patients about their allergy symptoms, oh, why are allergies so bad this year? Well, the season's longer, there's more pollen, and, just even explaining to patients about their disease, or if you're talking to patients about, for example, heat is a big one in San Diego, bringing in the conversation about climate change, even inserting a word, and maybe that oftentimes can be, I think, a signal to you how the patient responds. Some of them, they don't really want to have more of a conversation, but you'll find, I think, maybe that some of the patients actually will ask you more questions and want to learn more. So I think one is trying to sneak it in, and then responding to the feedback that your patients give you. And then ideally, we will integrate it into our infrastructure somehow, right? So do we have a population health process for addressing staying safe in heat and integrating some information about climate change? Is there a way? Do we have a team? Do we have asthma educators? I think finding our colleagues, maybe even non-clinical staff or other processes to integrate so the burden doesn't entirely fall on you in your 30-minute visit.
Yes, great. Any other questions from the people physically present here? Then we'll move on to, there is questions on the Zoom, and can read here. Thanks for enlightening us about the difference in carbon emissions for the DPIs and MDIs. I hope Symbicort DPI is brought to the US soon. Question, any way to reduce the use of PPE in the hospital without compromising safety? We use lots of plastics just for a few minutes use.
Yeah, thank you for that question. I think that is challenging because we have to balance, as we all know, safety of our patients and the healthcare staff. I mean, there's a few things. For example, even giving injections. There is no requirement that we use gloves. In fact, many of our infection control folks actually prefer that we would be using hand hygiene instead of using gloves. So that's just an example where we do things, but not necessarily because they're the right thing to do. Then there is a whole nother conversation about reusable PPE. There have been a lot of studies that have found that they are just as safe, and looking at the footprint, even with laundering, et cetera, in general, that the reusable PPE is going to be lower in terms of emissions. That's going to take a conversation that involves your infection control team. And then there's also conversations, I think, that need to be had about when we use PPE. So there are many institutions, including, I don't know what you guys do, but at UCLA, they had stopped using PPE with MRSA, other places with VRE. There's, I think, two camps about whether that is a good or a bad thing. But I think a lot of it will have to be related to your local community and your infection control collaborators on what makes sense and finding an optimal solution that balances safety, infection control, and environmental impact.
Yes, so I like the slide where actually the primary care physician was the most trustworthy profession. I want to sort of capitalize on that. What is, if we're going to give one sort of probing initiative towards the patient, introducing environment, again, sort of what should we ask the patient or sort of probe them? Because this is like motivational interviewing, and sort of over time, we create more interest and educate the patient. Where do we start?
Yeah, I think that's a hard question. I think that starting with where we can find co-benefits is probably the easiest. Co-benefits meaning something that is obviously so much better for our patients. And in fact, I might, if I can, I wonder if this still works. Oh, I do have that. Okay. This is not part of my talk here, but there was I wanted to give the example of going meatless. So, I mean, this is a graph that shows you, I don't know if you guys can see it still on. Okay, all right. So like if you look at mortality from eating red meat and you look at environmental impact, you don't want to be in that top right box. Where you want to be is on the bottom left, where you have low mortality and low environmental impact. This is a great example of co-benefits. Like really, you know, who wants to have a heart attack? Who wants to have cancer? So I think bringing in the conversation of what is healthy for the patients, but also maybe that extra little incentive or extra piece of information might be even more motivating for some patients. So finding areas where it makes sense for the patient's health. And there are many, as we talked about, like exercise, you know, deprescribing. I don't think patients want to be taking 20 medicines a day. So I think that would be where we should capitalize.
Yes.
Okay.
Yes. So Dr. Jassel's disclose that. No. Yeah, it was more a general sort of a pitch for the vegetarian food. So that's go green. Yes. I think that concludes our grand rounds. A very interesting topic. It's definitely something I need to incorporate my talk with my patients. So thank you very much.
I appreciate your moderating. Should I?
Yeah, so let's
Such a pleasure. I'm so
Yeah.
grateful to you. And again, I'm
Let's
so sorry about the lack of
properly
interest.
take
No,
this
again,
out.
I appreciate that.
Disappointing.
No, it's fine.
Enjoy your business.
Nice to meet you.
Do you want
Can I
to
just check that out, you think?
You can-
I don't need to eject it.
You can
Oh,
probably just-
okay.
Yeah.
Okay.
Okay.
All right.
Yes. Thank you so much.
Nice to meet you, and thank you for taking the
No,
time to
of course.
introduce the others.
Very interesting topic.
Thank you so much.